It is a pleasure to share with you a few interesting patients that we managed over the years. And I would try to explain to you certain interesting aspects of gastroenterology through these case snippets. Let me start with my first patient. This is a 50-year-old female who presented to us in July 2011. She had intermittent chest pain since January 2011. That means when she presented to us, she had intermittent pain for nearly 6 months. Pain was radiating to the back, left arm and shoulder. And each time she would have pain, she would have dysphagia and lot of retching, but maybe only occasional or no vomiting. So what could be the diagnosis and what could be the plan of investigation? One would say that the patient presented with intermittent dysphagia, which looks like motor dysphagia and is associated with chest pain. So somebody may think, is it esophageal spasm? So therefore, we would normally take up this patient for investigation for motor dysphagia. So let me tell you, just simply by history taking, you can differentiate motor dysphagia from mechanical dysphagia in a reasonable number of patients. Typically, motor dysphagia would be intermittent, whereas mechanical would be often continuous. It will be progressive. In case of mechanical dysphagia, it will be progressive. Typically, in motor dysphagia starts from very onset, both to liquid and solid, or in some patients even they may say they have more dysphagia to liquid than to solid, whereas in mechanical dysphagia, dysphagia starts with solid and then gradually progresses to liquid dysphagia when the esophageal lumen become narrower and narrower. The temperature of food does not affect dysphagia in patients with mechanical dysphagia. But in case of motor dysphagia, typically patient would say that they can swallow or eat the warm food better than very cold or chilly foods. Relation with posture. Typically, motor dysphagia patient over time learns to straighten their back, raise their arm to give some relief to their dysphagia symptom. That does not happen in mechanical dysphagia. Motor dysphagia is usually long in duration, mechanical is not so. Episodic esophageal chest pain, like our patient had, is highly suggestive of motor dysphagia, but not of mechanical dysphagia. Regurgitation is a feature of motor dysphagia, not of mechanical dysphagia. And in mechanical dysphagia, weight loss is usually marked, but not in case of motor dysphagia. Now this is how we approach our patient. We look at whether this is transfer dysphagia. Transfer dysphagia usually occur in oropharyngeal neurological disorder. Now there you will get nasal intonation of voice, nasal regurgitation of food as the typical symptom. But in esophageal dysphagia, typically dysphagia will be maximum, or patient will feel that food gets stuck just below the cricopharyngeus or even lower. So we do a history, do a physical examination, then one should undertake either a barium X-ray or upper GI endoscopy. Obviously, whether barium or upper GI endoscopy will depend on facilities. Like typically a gastroenterologist would tend to do upper GI endoscopy as the first investigation, whereas physician or those practicing in periphery may do a simple barium. Now, these investigations will tell us whether there is a narrowing in the esophagus, which means this is mechanical dysphagia, and if it is mechanical dysphagia, it may be either benign or malignant. Motor dysphagia The commonest disorder causing motor dysphagia is achalasia cardia. Other disorders I will not talk about, such as diffuse esophageal spasm, nutcracker esophagus or jackhammer esophagus. But since these are not as common, I will not talk about these, but I will talk about achalasia cardia. But let us come to our patient. In our patient, it was very interesting. The panel above shows a normal esophageal manometry, which typically shows a progressive peristaltic contraction with adequate relaxation of lower esophageal sphincter during swallowing. The lower panel shows the manometry tracing of our patient, and typically this tracing would be labeled as non-specific disorder because it does not conform to a specific disorder such as achalasia cardia. Now here I want to show you the chest X-ray of the patient or barium X-ray of the patient. In fact, barium X-ray I did not show earlier because obviously I wanted to keep the thing hidden from you so that you don't clearly see the diagnosis. Here in the barium you can see the diagnosis quite clearly. This is the esophagus. Below is the stomach. The trace of barium that is going down below the diaphragm is stomach. But you can see there is a sac-like thing with barium level at the level of G junction. One can say this is a paraesophageal hiatus. It looks like a paraesophageal hiatus. But there is something more waiting for you. I'll tell it later. Upper GI endoscopy that we did, we made a lot of before, but we could not cross the pylorus and reach the duodenum. And in fact, the diagnosis that came out in this patient later is a condition where typically upper GI endoscopy, the endoscopist would have difficulty to cross the pylorus and go to the duodenum. Now here is the barium swallow and meal of the patient, and what you can see is that in this patient the fundus of the stomach is below, whereas the antrum and the pylorus is above. This is volvulus of the stomach. Now volvulus of the stomach can be mesenterico-axial or organoaxial. In mesenterico-axial, stomach actually rotates around the axis of the mesentery. In organoaxial, the stomach rotates around the axis of the organ. Now, the mesenterico-axial will typically see that the fundus is below and the pylorus and the antrum is above, like in our patient. So this was a patient with volvulus of the stomach and CD did well after surgical correction of volvulus. So what were the clue in our patient to make this diagnosis if such patient comes again to you? One thing I told you during each episode of pain, one of the prominent symptoms that she had was retching, and the vomiting was occasional, if any. So typically, because in volvulus, the G junction gets twisted, and therefore there is a closed loop like or closed cavity like phenomena in the esophagus. So that the upper end of the esophagus is not only closed by the cricopharyngeus, here the lower end is also closed. Therefore gastric content can't come up to the esophagus, and therefore they don't have vomiting. They have a lot of retching but not vomiting. Our patient had this. Second thing that one patient may have is, suppose you are in periphery and a patient comes to you like this and you want to pass a Ryle's tube and you find it is very difficult to pass the Ryle's tube below the esophagus into the stomach. Suspect volvulus. Third thing, on upper GI endoscopy, we could not go to duodenum. This is also a feature of volvulus of the stomach. So very interesting patient, I believe. I think you will agree with me. Come to our second patient. This is a 28-year-old female who presented to us with dysphagia particularly to solid, heartburn, occasional bleeding per rectum, and loose motion. She responded to glucocorticoid but not to PPI. And since she had bleeding per rectum along with dysphagia, and there were some endoscopy finding which led to the gastroenterologist thinking that he is dealing with a patient of esophageal Crohn's disease, because on one side you have dysphagia and on endoscopy you found some features like ulcer, cobblestoning and all, and on the other side there was bleeding per rectum. So therefore a Crohn's disease was thought. At this stage patient was referred to us. We did a 24-hour pH metry because this patient also had heartburn. I'm not saying that you should do that in every patient, but I'll tell you later why we had to do. So 24-hour pH impedance did not show any reflux. We did one esophageal manometry, and I'm showing the esophageal manometry to you. Now what you can see on this manometry is that there is beautiful peristaltic contraction. The upper esophageal sphincter opens with each swallow. The lower esophageal sphincter, as shown here, opens with each swallow, and there is beautiful peristaltic contraction. Now I tell you, these are all liquid swallows. And remember one thing, our patient presented with dysphagia particular to solid. So if you just do a liquid swallow manometry, would you expect that the abnormality will be found? Obviously no, because the patient did not have dysphagia to liquid, but she had dysphagia to solid. So therefore in such patient, we would do a viscous swallow manometry, and on viscous swallow manometry, like by giving applesauce, what we found is she had multiple failed peristalsis. So here, though esophageal manometry with liquid showed normal esophageal manometry with viscous, as shown here, showed failed contraction. So you can understand why she was having dysphagia to the solid swallows. Now at this stage, I'll show you the endoscopy. In fact, endoscopy we did earlier than this, but I did not show you so that diagnosis doesn't become clear. On endoscopy, what you can see, there are linear furrows in the esophagus. There are multiple linear furrows in the esophagus, and there is trachealization of esophagus. So therefore, a diagnosis of esophageal eosinophilic esophagitis was made in this patient based on an esophageal biopsy. In fact, for diagnosis of esophageal eosinophilic esophagitis, what you need is, you need to exclude gastroesophageal reflux disease, which we excluded by 24-hour pH impedance monitoring. The endoscopy finding was classical, and on biopsy, you have to show more than 15 eosinophil per high power field on esophageal biopsy, which this patient had. In fact, she had eosinophilic abscesses. And you know why she was responding to corticosteroid? What is recommended in eosinophilic esophagitis is to stop all the allergenic food. These are beans, milk, wheat, egg, and seafood. And we treated this patient with systemic corticosteroid because she did not respond to inhalation of corticosteroid. We also had to give montelukast, and her dysphagia responded. So in eosinophilic esophagitis, people have shown that if you do a liquid swallow manometry, it may be normal, but with solid swallow or viscous swallow, they often have abnormalities, and this case reiterates this fact. Now let us come to the third patient. 39-year-old female teacher. She presented to us in November 2016 with dysphagia since August 2016. So that means she had dysphagia for almost 2 to 3 months before she came to us. This was non-progressive and only to solid. Now I told you dysphagia to liquid or dysphagia to both solid and liquid from the very onset is suggestive of motor dysphagia. But in this patient, dysphagia to solid means this is less likely to be motor dysphagia. She did not give history of weight loss, fever, GI bleeding, vomiting and loose motion. She underwent investigation elsewhere. Ultrasound showed hepatomegaly and retroperitoneal lymph node. CT scan showed thickening of the gastric antrum. On upper GI endoscopy, there was nodular proliferative lesion in the antrum. Biopsy showed granuloma, which was negative for acid-fast bacillus, both on smear and polymerase chain reaction. If I show you the endoscopy feature of the stomach in this patient, you can see we are now in the antrum and you can see close to the pylorus there is nodularity and there are ulceration with yellow slough. So this is the finding, and you know on CT scan she showed thickening of the antrum, which means her lesion was confined to the antrum. Now one would say, what are the differential diagnosis? In the differential diagnosis, one can think about malignancy such as gastric adenocarcinoma. One can think of another malignancy, that is lymphoma. Third thing that you can think about is benign disease such as Crohn's disease, even gastric tuberculosis, though it is rare, still it should be kept in the differential diagnosis. And we reported 1 or 2 patients presenting like this with thickening of the antrum turning out to be gastric amyloidosis. So let us see what we did to this patient. What is the diagnosis? Now her MAN2 test showed that the MAN2 was 25 millimeter. Chest X-ray was normal. Remember one thing, in 15 to 25% patient only with GI tuberculosis you can have chest lesion of tuberculosis, because in all extrapulmonary tuberculosis one is supposed to do an HIV. We did that and it turned out to be negative. She did not give consent to undergo colonoscopy, hence colonoscopy could not be done. So if I get a patient like this with 25 millimeter MAN2 with a lesion in the stomach like this, which is nodular proliferative, which turned out to be negative for malignancy but showed granuloma, I would think about tuberculosis as one of the differential diagnoses, rather it is one of the important diagnoses. Though it was negative for acid-fast bacillus by smear and culture, we all know that GI tuberculosis is paucibacillary disease, hence negative AFB does not exclude the diagnosis of tuberculosis. So what next? Now this is the barium picture. You can see that there is a narrowing in the pylorus. We started her on ATT or anti-tubercular therapy. She gained weight, her symptom improved. But what happened is she was having symptom of gastric outlet obstruction, and on repeat endoscopy in January 2017, we found the ulcer got healed, but there was a pyloric stricture. So we dilated the pyloric stricture using a CRE balloon. And in fact, in the earlier days, when all these endoscopic therapies were not available, one would do gastrojejunostomy for patient with gastric outlet obstruction. But in this particular patient, we did not have to do that. We just did pyloric dilatation and she was on follow-up and doing well. Now one would ask, now you have given ATT with 4 drugs. So how long should you give ATT? Should it be 6 months or should it be 9 months? Now earlier it was thought that GI tuberculosis, you should not give 6-month therapy, but you should give 9-month or 12-month therapy. Now in pulmonary tuberculosis, yes, you can give 6 months. So therefore, revised National Tuberculosis Control Program, the government of India wanted us to do a randomized control trial to see how long should we give anti-tubercular therapy in patient of GI tuberculosis. And we compared 6 months versus 9 months dots. So with 6 month and 9 month dots, randomized control trial, with what we found that efficacy of 6 month therapy and also relapse rate after withdrawal with 6 month therapy was similar to 9 month therapy, and this suggests that even in GI tuberculosis 6 month therapy is enough, and obviously this study would be important because it will lead to cost saving for the government and the country. But one would say, how many patients of gastric tuberculosis did you have in this series? Unfortunately, we did not have a single patient of gastric tuberculosis in this series. But I believe since GI tuberculosis is a paucibacillary disease, both gastric tuberculosis and intestinal tuberculosis, I think this will apply to gastric tuberculosis as well. Now let us come to case 4, 45-year-old male, right upper quadrant pain for 1 month. It used to be severe colicky, not radiating. It was intermittent, and each time he had associated vomiting. There was no jaundice, fever or obstipation. So one would agree with me that if we have a patient who has severe right upper quadrant intermittent colicky pain, you will think of gallbladder colic as one of the, or biliary colic as one of the differential diagnoses. If it is biliary colic, what will come in your mind? You will think about only gallstone. But remember, in India, you cannot forget one more entity which can present just like gallstone or CBD stone. This is round worm. Now, what we did in this patient, the patient carried an ultrasound abdomen from elsewhere, which showed a linear filling defect in the common bile duct. Also MRCP or magnetic resonance cholangiopancreatography showed a linear filling defect in common bile duct. Hence the diagnosis was biliary ascariasis. Now we did an ERCP, and can you see here, this is the biliary sphincter that we have cut open. Now what we saw is this is the worm that came out when I was trying to extract the content of the bile duct by an extraction balloon. So this blue color thing is extraction balloon, and this black thing is the roundworm or ascaris. Obviously the ascaris is normally white, but in this particular patient the roundworm got impacted in the bile duct and actually had the fatal end, and after its death it became black. And subsequently we caught hold of this worm with a Dormia basket and took it out. So what I wanted to tell you is that in the literature, India has contributed in this field enormously. And this is a study from Mohammad Sultan Kuru from Sere Kashmir Institute of Medical Science in 1990, published in Lancet. And this was a series of about 500 patients with duodenal, biliary and pancreatic ascariasis. And what he found is such patients who present with severe right upper quadrant pain, particularly in India, one should think about biliary ascariasis. Now, only thing interesting in this study is that most of the worm don't get impacted. The reason is once they get impacted in the CBD, it will lead to a fatal end in their life cycle. So therefore they don't get impacted. They just peep through into the CBD and then come out. But in this 500 patient series, about 12 had impacted worm in the common bile duct like our patient had, and this is an uncommon occurrence. So getting the linear filling defect is an uncommon occurrence, and you should suspect biliary ascariasis in patient of recurrent right upper quadrant pain. Now let us come to case 5, 42-year-old farmer. He had weakness and easy fatigability for 2 years. He had recurrent melena for 1 year, 4 episodes, each episode lasting for 3 to 4 days, and there was no hematemesis. There was no history of subacute intestinal obstruction or non-steroidal anti-inflammatory drug intake. He took oral iron and 2-unit blood transfusion once 2 months ago. Stool for occult blood was repeatedly positive. Microscopy did not show ova or parasite. An upper GI endoscopy and full-length colonoscopy were normal. So what is the diagnosis? That this is a patient who is having recurrent maligna, no hematemesis. So if hematemesis, absence of hematemesis suggests it is less likely to be occurring from the esophagus, stomach or duodenum. Maybe it is occurring from below, from the small bowel or right colon. Now this patient also has stool occult blood positivity repeatedly, which suggests that he is having GI bleed. Now once upper GI endoscopy is negative, means upper GI cause for the bleeding is unlikely. Full length colonoscopy is negative, that means the bleeding must be occurring from small bowel. This is called obscure GI bleed. So what is the obscure GI bleed? In a patient of GI bleed in the form of maligna, hematemesis, both, or just iron deficiency anemia, mostly with occult blood positive, mostly with stool occult blood positive. If an upper GI and full length colonoscopy are normal, this will be called obscure GI bleed. Those who present with maligna or hematemesis, this will be called as obscure overt GI bleed. Those who present without maligna or hematemesis, this will be called as obscure occult GI bleed. So obscure GI bleed is of two types. Occult means here there will be stool occult blood positivity and or iron deficiency anemia, or it will be overt where there will be hematemesis and or maligna. Now our patient has obscure GI bleed which is overt. Now what next? What investigation would you do? But before I go to the investigation, let me define what is upper GI bleed and what is lower GI bleed. Typically it has been said to us, or it has been taught to us, that if the bleeding source is located above the ligament of Treach, this is upper GI bleed. If bleeding source is located below the ligament of Treach, this is lower GI bleed. But this classification has a major issue. How do you see ligament of Treach? On upper GI endoscopy, we can't see a ligament of Treach. On colonoscopy, we can't see ligament of Treach. And if you do barium, even there, barium is a very poor investigation to pick up causes of GI bleed. In fact, one study showed that yield of barium was 10% to pick up causes of obscure GI bleed. Therefore, this ligament of Treach definition is fallacious. So that's why nowadays it has been defined, GI bleed has been defined as upper guard bleed, mid guard bleed and lower guard bleed. What is upper guard bleed? Upper guard bleed is the bleed in which the lesion is within the reach of an upper GI endoscope. Lower GI bleed is the bleed in which lesion is within the reach of a full-length colonoscopic examination. And mid-guard bleed is the GI bleed where the lesion is in between. So our patient obviously had mid-guard bleed according to this definition. What is the investigation for that? The investigation for that is small bowel endoscopy. Small bowel endoscopy, one of the great method is capsule endoscopy. And you see, Israel is a very small country. We talk about make in India. How do you make in India? We talk about skill India. How do you develop skill in India? You have to empower people who have skill. You have to empower people who are educated. Then only you can make it. Now this is Paul Swain, and he is the father of development of capsule endoscopy. Now this was developed in Israel, which is a very small country. Now what it does is, this is not really a capsule. This is a video camera. This video camera goes inside our GI tract and take 2 images per second. In fact, nowadays, the frequency of image has been increased from 2 images per second to more than 2%. Also, it has 4 light emitting diodes. What does light emitting diodes do? The moment this video camera actually takes a picture, simultaneously the light emitting diodes actually flashes so that the inside has light to capture the lesion or take the picture. Not only that, this has a radio frequency transmitter. So what does this radio frequency transmitter do? By the same method as the radio signal, each of these image is actually transferred to a computer outside the body of the human. So what this video capsule is doing, it is taking picture while the light is flashing, and the moment it takes a picture, it is sending the picture to a computer outside. Now we all know that if we see multiple still picture with a speed, now you see it not as a still picture but as a video picture. So therefore, by this technology, you can see a video of the small bowel like a movie. And in fact, this is analogous to a movie. This movie is called Fantastic Voyage. In this Fantastic Voyage, it was developed much before the capsule endoscopy discovery. It shows that a human being is miniaturized, then he is injected into the blood vessel, and now this human being goes inside the blood vessels of the human brain and fires the lesion, heals the lesion, and comes up. So this is Fantastic Voyage. Obviously, it was like a science fiction movie. Now this is no more a science fiction. A small country like Israel has developed it, and it made them very rich. Now this is one of the technology which contributed to the economy of Israel in a big way. So I say, to make in India, to have skill in India, now what you have to do is empower those who have skill and empower those who have education. Now forget about this. I'm talking about, this is the principle of capsule endoscopy, which we published in one of our review paper. I've already elaborated it to you. Now let us come to our patient. This is the patient. Now when we did the capsule endoscopy, what we saw, dancing white linear structures. Dancing white linear structures. Now inside this dancing white linear structure, there was red material, which is blood. And these linear worms were aggressively puncturing the mucosa of the bowel here and there and sucking out the blood. So this is hookworm. So hookworm infestation, hookworm drinks blood. So it punctures the bowel mucosa, it drinks blood. And what happens is that because it drinks blood, therefore it causes anemia. Now this is a technology of today has been developed, or it has been applied to a country which is somewhat backward. Like India obviously is not as forward as Israel. So in India we get tremendous worm infestation. Obviously Israel they don't get. Now we developed a technology which is the current technology, and we found the lesion which is occurs in a country which is somewhat backward. Now I tell you, this particular case challenged the existing concept. What is the existing concept? Existing concept is hookworm cannot cause obscure overt GI bleed. The reason is, I tell you, the hookworm drink only 0.3 ml blood. Each hookworm drink only 0.3 ml blood every day. So therefore the concept has been the hookworm causes only anemia, iron deficiency anemia, and it cannot cause frank GI bleed. But look at this series that we published. In fact, this is the largest series of hookworm causing obscure GI bleed in the world. We did by this time about 163 patient capsule endoscopy, and 21 we found out the hookworm was the cause for the obscure GI bleed. Now look at that, 16 had obscure overt GI bleed and 5 had obscure occult GI bleed. So it actually challenges the concept. It says yes, hookworm can cause obscure overt GI bleed. We also found that the prognosis of the patient was worse if they had not only hookworm infestation but another lesion causing obscure GI bleed than hookworm alone. But how do you explain this? See, each hookworm causes 0.3 ml blood loss daily. Okay? And we all know at least 50 ml blood loss is required to cause melena. So how much blood loss is required to cause melena? In a day, one has to lose 50 ml blood in the bowel to manifest as melena. But hookworm causes bleeding of only 0.3 ml per day. This is the reason why people thought hookworm cannot cause overt GI bleed. But let me tell you, hookworm inside the bowel can be 1,000. It can be thousands of hookworm causing the bleed. So 0.3 ml blood per worm and 1,000. How much? It becomes 30 ml. If it is 2,000, it becomes 60 ml. More than that, when hookworm punctures, the punctured lesion keeps on bleeding. Also, hookworm produces anticoagulant substances. And because of the production of anticoagulant substance, the lesion keeps on bleeding. Also, there could be co-infection with other worms such as strongyloid. And we all know strongyloid causes auto-infection causing high worm burden, which can lead to massive GI bleed. And I showed you there could be presence of another lesion. So these are the 4 reasons by which we can explain biologically hookworm can cause obscure overt GI bleed. Now, thank you so much. I shared with you a few interesting patients, and I think this is the best way to learn clinical medicine. Like, best way to learn clinical medicine is not reading only the book chapter, but reading your patient. And I hope this has been useful to you. Thank you so much.